Kirsten, if you want to roll.
Okay. Well, good evening and thank you for joining us for an interactive roundtable discussion on women's health and racial disparities in healthcare. This event was organized by members of the State Board, of the Women Lawyers Association, of Michigan, the Wayne Region Board of Women Lawyers, and the National Association of Women Judges. The idea of this panel came up during one of our Wayne Book Club discussions, and with the amazing assistance of our committee, grew into this remarkable event that we have for you all tonight. I want to thank our committee members for assisting in planning this event: Erin Klug, Shanna Kaminsky, Patty Woodruff, Corey Barkman, Michelle Rick, and Zenell Brown. I, of course, also want to thank our panelists for joining us, but I'll leave that to Zenell to introduce them once we get started here. Before we begin, I just wanted to go over the agenda with everyone tonight. First, we are going to have a wonderful discussion amongst our panelists. Following this, we will open up to the audience for questions and personal story sharing. Please also keep in mind that this is going to be recorded. We will be posting this discussion on our YouTube channel following the event, and we are currently live streaming on Facebook as well. However, when we move into the Q&A portion of this event, because we will be having people sharing personal stories, we of course will stop the live streaming and recording. So let's get this discussion started. I'm happy to introduce our wonderful moderator, Zenell Brown. She currently serves as the Executive Court Administrator of the Third Circuit Court. She's a certified diversity professional and co-author of a state court administrative office state court administrative office approved mediation training curriculum. Zenell serves on the board of the Detroit Bar Association, the board of the Michigan Diversity Council, several committees of the National Association of Court Management, the faculty of the Michigan Judicial Institute, and the faculty of the Institute of Court Management. Finally, we of course are proud to have her as one of our WLAM co-chairs of our Diversity and Inclusion Committee this year as well. So Zenell, take us away.
Thank you, Kirsten. Good evening, everyone. So glad to be here. So I'm going to start by introducing our panel. First of all, we have Dr. Amy Cortez. Dr. Cortez received her medical degree from Wayne State University Medical School and completed her pediatrics residency and pediatric emergency medicine fellowship training at Children's Hospital in Detroit. She provides emergency medical care to pediatric patients at Children's Hospital in Detroit and Troy. Prior to medical school, she worked for Women's Health Program and Adolescent Health Program at the University of Michigan University of Michigan Health System doing community outreach. Dr. Cortez is passionate about the health of children and their family, locally and abroad. She is on the Wayne State University Global Health Alliance Board of Directors, and in her spare time, she volunteers her time providing medical care and health education to homeless families residing in Samaritas Center in Westland, Michigan. We also have on our panel, Michelle Johnson Tidjani. Michelle is an attorney. She's the Senior Vice President and General Counsel for Henry Ford Health System. She was appointed in this position in 2017. In this role, she provides executive leadership, both from a strategic and operational perspective. And she covers the offices of General Counsel, the Business and Integrity and Tax Office, Information Privacy and Security, the Governance Office, Risk Finance and Insurance Office. She has received numerous awards for her leadership, including the Crain's Detroit Best Women Lawyers, Michigan, the Michigan Chronicle Woman of Excellence, Wolverine Bar Association Golden Gavel Award. She's earned her doctorate, her Juris Doctor from the University of Detroit, University of Detroit Mercy School of Law. And she was awarded her bachelor's with honors from Cornell University. She's married, has 2 children, and is a native Detroiter. We bring to the panel as well, Emily G. Thomas. She's a trial lawyer who focuses her practice on aiding clients with special needs and disabilities. What stood out for me is Emily's experience comes based upon her personal experience with those clients who she believes that the judicial system often seems too complex to understand and intimidating. So she sees her role is to help clients with special needs understand their rights, their case, and most importantly, ensure them justice. She's been focused in this area for over a decade now. She remains committed to learning medicine as well as law and explaining both in a way that courts and juries can appreciate. Additionally, on our panel, we have Mary Placido, and she has a lot of initials behind her name: MSN, FNP, hyphen BC, CCRN. And definitely she's going to have to tell us what all of that means. After earning her master's in nursing from the University of Michigan Flint and board certification as a nurse practitioner, Mary started working at Beaumont in the IC unit in January 2020. During the pandemic, she worked the front line in the ICU, and she was redeployed to care for COVID patients at Beaumont Dearborn throughout the summer. Mary's career in medicine spans over 20 years, from her start in the healthcare field in the United States Army to work as a paramedic, which she did from 2003 to 2011, then critical care nursing from 2011 to 2020, and nurse management from 2015 to 2020. In addition to working full-time, Mary is a full-time student pursuing a doctorate of nursing practice at the University of Michigan Flint. Her interest is in mental health, and she's doing this while raising 2 children and a husband. So we have a very qualified panel here today, and we're going to tackle the issues of women's health and also racial disparities as far as women's health care goes. So good afternoon, panelists.
Good afternoon.
I want to start, well, good evening now, right? We're home from work. So I want to start with this question about access to care. We know that everybody does not have equal access to care, and it could be different whether it's an educational difference, mental health difference, whether it's economics. Even history shows that it's never been like an equal access to medical care. And so, Emily, I'm going to toss it to you first, just to get some of your insights on that.
Well, I have a unique perspective because I actually, full disclosure, I have no medical background at all besides what I've learned over the last decade and working with clients, many of whom who have suffered injuries because of medical mistakes. And, you know, a lot of my clients, and I shared this when we had the roundtable, you know, I'd say 90% of them are Black. And there definitely is a disparity, especially what I focus in, which is in cases that affect women and children. You know, there's a reason that that percentage is so high in the cases that I see, particularly in Detroit and the Metro Detroit area. But in the US as a whole, we know that Black women are more likely, 4 times more likely than a white woman to die as a result of childbirth. And so they're clearly, you know, just in my experience, in the cases I've handled, there's a great disparity between clearly the races and also between women and men in terms of medical, you know, misdiagnoses and you know, missed opportunities really to make sure that people are as healthy as they can be. And we have great medical providers. I'm so honored to sit on the panel today. Thank you for inviting us to be here. I'm sure that they have a very unique perspective and thoughts that they can share on this issue as well. So I'm gonna punt to them.
Okay, so Dr. Amy, will you take it from there?
Sure. In the pediatric realm and in the setting that I work in is a little bit different because of all of the children in the state of Michigan do have access to healthcare. It might not be equal access, but they all have the ability to get insurance strictly because they are children. What I recognize in the emergency department setting is that I provide, in addition to emergency care, I provide a lot of primary care because of the access issue. And when we talk about the access issue, we don't have enough primary care providers in the city of Detroit to care for all of the pediatric patients in the city. And if parents are working, they can't necessarily get there during the allocated times of 9 to 5. Transportation is a huge issue. And so they're very dependent upon these other systems. And so again, I find that in my setting, I'm providing a variety of services, not just emergency care. So I think that there's a huge disparity when it comes to access. strictly because of geographics in the city of Detroit at this point in time. So I find that extremely frustrating. Like I said, I am honored to be able to take care of children, and it's fortunate that we do have legislation that makes sure every single child is insured. But saying that at the same time, when we talk about the disparities, especially with the issues with birth rates and things like that, this is a huge problem in terms of not ensuring everybody to make sure that they can live a happy, healthy life. The pediatric patients I care for are dependent upon their parents. So if they're not healthy and they're not practicing healthy lifestyles or able to get access to care, their children are not going to be able to do the same.
So Dr. Amy, you're saying it's like a generational type of pattern that you see. If the parent doesn't have good health, the child doesn't have good health?
I think the children that I take care of, all of the parents are doing the best that they can. But again, I think it's hard to promote healthy lifestyles if you don't have the ability to access the healthcare and things like that. So I do feel like there is some generational component. And that's partly not just healthcare, but that's a lot of education. And so I think we have a long way to go.
Okay. Nurse Mary?
Mm-hmm. Yeah.
What's your perspective? And,
Oh,
and please let us know what all of those initials were that I read off.
Sure. I have my MSN is a Master's of Science in Nursing, and then the FNP-BC is my certification for family nurse practitioner, and then I'm also a certified critical care nurse. That's what all that means. So
that means you're qualified to answer. Go ahead.
Yeah, I think maybe. So I would agree with Dr. Cordes. I feel like I see patients in the ICU. So at that point, they've already been triaged through the emergency system. But in the area where I work, which is Beaumont Wayne, that community is socioeconomic status is on the lower end. So there is a lot of utilizing the emergency room as a primary care. Patients showing up in the ICU with lots of comorbidities that have not been managed in primary care, and which has gotten them into a sad shape in the ICU. And I would say, unfortunately, during the COVID, when they closed Beaumont Wayne, it was a big disservice to that community that had been utilizing medical services there, because when that was shut down, a lot of the primary care medicine, because there's a big family medicine residency program there, all of that was curtailed as well. So people that were being seen in clinic were no longer, and were forced to go to different ERs and everything like that. So we have a lot of work to do.
Wow. Michelle, we have you on mute. Do you want to come off and speak on this part too?
She might be frozen.
Yeah, looks like it might be frozen.
I was wondering, was that a profile picture or was she frozen?
Oh,
There she is. Now you're frozen again, Michelle.
No, I'm
Okay.
frozen.
You're
Can you hear me?
unfrozen. We can hear
Okay.
you.
All right. So I would just agree with all that we've heard to date. I don't know that I would add anything except that the complexity of healthcare goes so far beyond actually access to healthcare, right? So healthcare is one component of the overall health of individuals. And one of the things that sometimes providers don't appreciate as much, and I can say that having spent my entire career representing physicians in hospitals, is that people didn't show up for an appointment for a reason. Oftentimes people are making really, really complicated decisions around whether or not to eat, or how am I even going to get to that appointment? And if I go to that appointment, I miss work. And so the complexity of the healthcare dynamic is just that complexity. And so this is why, a lot of organizations have moved toward sort of a broader health-based strategy. Oftentimes it's referred to as population health, right? Because the idea that we're only responsible for what happens when you come through our ED or when you're present for a physician visit is really short-sighted. There is the entirety of making sure that your overall health is in check. And that requires me to make sure that you've got food to eat, that you've got a way to get to your appointment, and that some of your other social needs are met. And so more and more today, I'm just going to say more than at any point early in my career, we're really focused on the entirety of the healthcare interaction experience, which then captures the things that lead up to you coming to that first appointment, which is actually ideal state, or coming through the ED, not ideal state, but at least an opportunity.
What's the ED?
That encounter. Oh, the emergency department.
Okay,
Sorry,
gotcha.
the emergency department, right? Because a lot of people use emergency department access. If you're an adult, right? So if you're not a patient, if you're a child, you've got, access to healthcare if you Medicaid. But if you're an adult and uninsured, it is very difficult to get an appointment, right? Because I want to go to primary care. Someone said, an aunt, a brother, or sister said, I should go get that problem checked out. But when you call to make an appointment, the first question is, what insurance are you using, right? And if you don't have insurance, right, likely because you are unemployed or working for an employer that doesn't offer a health benefit, then you're left to paying cash for a visit. And to be clear, people don't collect real.
She was making a very good point and got cut off.
Well, I can talk. Oh, there she's back.
You got cut off, Michelle.
Michelle, you were on a roll.
Okay, sorry. Well, so bottom line is, without insurance, your resources, your ability to access care is incredibly limited. And
Okay, Michelle, we're going to have you come in on your iPad, if you can switch your devices. But what I was understanding from what she was, you need it on your other device because you keep freezing. What I was understanding is that I'm asking about access to health care, but it's like, no, maybe there's something even before that. It's the access to insurance. It's the access to having the ability to make sure that you have the preventative care going on, or the holistic systems that make you healthy.
Absolutely. That's I think a huge part of it. And if you don't have insurance, well, then your option becomes the emergency department, because there's federal law that mandates that when people come to an emergency department, they need to be served. But there's also the fear that comes along with, if you don't have insurance, what is that bill going to look like? Can you afford to go to the ED, even though maybe you really need care? And I see this for, I work with families that have, an injured loved one or child. Going forward, insurance only pays for so many visits from therapy or certain types of procedures or certain types of care. So you also, just even as an insured person, in the back of your mind are thinking, well, what is this going to cost me, copay or out of pocket or bills down the line? There's a great Vice YouTube video, I think it was Vice, of a guy who his wife was expecting a baby. And so he called all these hospitals trying to figure out exactly what the cost would be for his wife to have the baby with, and they were insured, and no one could give him a definitive answer because it depends. It depends on what happens during her pregnancy, what happens during the delivery. And, I think that speaks to a lot of the problems with our healthcare in America when we don't, know what things cost, or we might deter people from getting care because of the cost.
Okay. So one of the things that also comes up is like, okay, so I made it to the hospital, or I made it to the ED, or I made it to my doctor's appointment, and I'm there to receive the care. What are some of the barriers as far as me showing up as the patient, getting the care that I actually need?
Well, oftentimes people show up, if you meet a provider who is new to a space or doesn't have a lot of experience with diverse populations, oftentimes my complaint of pain isn't heard quite the same way. And the options in terms of treatment may not be fully made to me. And it's not because I don't believe that people show up one day, for example, and say, I just don't want to deal with poor people, or I just don't want to deal with people of color. Oftentimes there are issues of unconscious bias that arise in terms of how we provide care and deliver treatment. And so one of the things that people always have to keep top of mind when you're in serving populations, which in healthcare, I mean, we are here to serve others, either as providers or administrative folks, we're here to serve others, is to be mindful and quite conscious of our own biases so that we hear the voices, we hear the pain, we hear the concerns, and are thoughtful about the sort of inquiries that we make so that we can fully assess the situation. I'll pause. There's so much more, but I will be frozen.
Would anyone else like to weigh in on that? What are some of the barriers as far as me when I show up in the doctor's office from getting the care that I actually need?
Well, so for me, from my perspective in the cases I've handled, especially with my Black clients or my young teenage moms, I think that complaints from especially young moms, and particularly mothers of color, they have legitimate concerns about things that are wrong with them that I often think, I don't know if they're not perceived or not listened to by the doctors. And that's an ongoing theme. You know, I work really hard to talk to the jury after my cases are tried. And they will often, the resounding theme is when it turns out well for my client, when they find out on behalf of my client, they say, you know, the doctors and the nurses, they just didn't listen. They weren't listening. The you know, young mother was saying, I'm having this pain, I'm having this nausea, I can't keep the food down. And they just keep giving, you know, Zofran or anti-nausea meds and not doing more diagnostic testing, not investigating further to look and listen, really listen to the mothers, and investigate as to what's going on. So, you know, I just see that as a pattern again and again. And we talked about this in preparation for this panel, but often where things go wrong, and obviously I'm biased because I only get to talk to moms that things have gone wrong or families where things have gone wrong. It often is a breakdown in communication. You know, there are warning signs. There's things that the parent is doing and they're relating to the doctor, but for some reason they just don't get investigated. And so I think, you know, for things to go right, that relationship, and to be able to be aware of those unconscious bias and say, you know, this mom keeps complaining about this. It's the fourth time she's been here, the third time. Maybe there's something else going on. You know, clearly that gets broken down. That communication gets broken down. That's what I've seen over my career.
You know, I would just follow up with that. Oftentimes I ask providers, what would you have said if that were your daughter? What would you have said? Filter through all of the noise of there are two other kids in the room. There's a lot going. What would you tell your daughter? And let's think about that in terms of the standard, because oftentimes, you know, the doctor-patient connection is a relationship, right?
Well, let's ask the doctor. Doctor, what is it that you want us to tell you when we come in so we can get the treatment that we need? You got to come off mute. I know the attorneys are very boisterous, so I'm trying to tame them.
It's absolutely a relationship. And I have to agree with you 100%. I'm going to first start by saying medical education it has a long way to go. It really does have a long way to go. There is a huge push right now. There's at this point in time, actually 50% of the medical school class at Wayne State is female. So we've made headway in that direction. However, we have not made headway in terms of my African-American colleagues in the medical field. With that said, there's still, again, a lot of work in terms of the curriculum. Talking to patients is not a priority in the curriculum. Your anatomy, your physiology, your immunology, your pharmacology, those are the things that are a priority. And it's really unfortunate to me that that's the direction. I can go back and tell you all the pitfalls in my medical education. At the same time, however, I think it's important to consider a lot of people going into medicine now are going into specialties for a reason. Primary care is extremely difficult. And when we talk about that relationship, that's critical. The relationship is critical to the patient and the care that they're going to get. So the one thing that I had a friend comment to me when I decided to go into pediatric emergency medicine. That was a decision. It kind of just happened. I always anticipated I would be a pediatrician, and I expected I would work in the community and do general pediatrics. And I had a friend say, well, don't you want a relationship with your patients? And my response to her was, I do want a relationship with my patients. And my job is just that much harder, that I have to get my patients and their families to trust me in a very short period of time so I can provide them with the care that they need. I think there's also this, it's difficult in terms of the pressure that's being placed on physicians. And I'm not saying that this is right or wrong, but the healthcare system is under a lot of pressure. Right now, someone is monitoring and tracking from an insurance perspective every single chest x-ray I do on every single patient. and I get a report to tell me where I fit in with my colleagues, if I'm doing too many chest x-rays or not enough chest x-rays. They're not looking at the particular situations. They're not reading my note and understanding what my medical decision-making was and why I thought that was indicated. They're just looking at the numbers and the tests that I'm doing. Unfortunately, I feel like sometimes patients feel like I get compensated when I do more tests, which is not the case, like I just told you with my example. So I think we really have a long way to go in terms of the system and helping people to understand what kind of challenges we're faced with when a child or a woman comes in to get medical care.
So if I were coming in as a patient, what would be the best way that I should present myself to you as far as, hey, Dr. Amy, I'm not feeling well? What would that conversation then evolve into?
When someone comes in and tells me that their child isn't feeling well, because those are the patients that I take care of. But
Right.
I'm going to be honest with you and tell you, parents know their children. And so that is one thing that I wish I work with medical students all the time. And if I walk out of a room and a family still is not comfortable, that's the situation when I need to turn around and sit back down and say, what is going on? What is making you uncomfortable? How can we make this better? Unfortunately, always admitting a patient to do more tests isn't going to get us to the answer. So I think that's one of the biggest challenges of my job. I want to help families get to the answer, but it's not always staying in the hospital and accruing large medical bills for nothing to be done. So I think when families come to the emergency department setting and they're under my care, I take my job as helping them navigate the system very seriously. I am their entrance into the medical care system, and it is my job to help them figure out the next steps. Obviously, I need to figure out if their child is that sick that they need to stay in the hospital, but then what is the next step in terms of getting them what they need for their child?
Okay. I know oftentimes, like in the legal field, when we are seeing someone in that crisis situation, it's very hard for them to listen to you to take the direction that they need to get to the next step. So, Mary, how do you deal with that to make sure that that person actually understands how to navigate through this?
Yeah, I think in the ICU, that's every day is the moment is that acute, everybody's panicking type situation. And we have to like step back and talk to the families and really utilize the families to help the patients understand what's going on. And then we often have multiple conversations over multiple days about how this is all progressing. I think my background as a bedside nurse has helped me. I understand like where patients are coming from because you spend 12 hours a day at their bedside. So I think that helps me a little bit in my role as a nurse practitioner. But I think the things where it might not go so great is when you don't have the continuity of care with the same providers. I think, and even seeing transitions of new nurses and everything like that, like they don't have that big picture knowledge either to be giving full picture explanations to patients. So we could do better at that. I think and oftentimes we can have a different physician each day in the ICU. So that makes it very tricky to keep on the same plan for these patients every single, you know what I mean? So that makes it a little tricky.
For my personal experience, I know that just looking at my family, that oftentimes seeking the medical care is what we do after we've tried every home remedy that we could think of. And then somebody says, oh, you need to go to the doctor. And then we sort of go with this blinded look, no matter how intelligent we are in our regular lives. It's like we sort of just give up all of that. And doctor, you tell us what to do. And we just sort of blindly take, the information and oftentimes not even really hear the information. So we're often not timely as far as going to get the treatment that we need when we should show up, and then not fully engaged to appreciate what you're saying to follow through on it. And then God forbid that we feel better the next 2 days. Your follow through is, no big deal.
Can we talk about that patient compliance and follow through from the medical providers? Because this is an interesting issue in my cases, right? Is if the doctor asks a patient to do something, jurors expect that patient's going to do it. But sometimes there are reasons that we kind of talked about, transportation, access to getting a script filled at the pharmacy. Do you have a pharmacy that's going to fill it? And, what if you call the pharmacy and they're out of stock? I have a lot of patients that they become pregnant and they are uninsured and they have to wait to get Medicaid before they can then go get those scripts, even if they have pre-existing conditions that need to be filled. So I'm very interested about this topic of compliance and follow through from patients, what you guys think about that.
I think, again, our system has a long way to go. I don't think that that's a priority right now. So again, as a physician, I can do my job within the realm. I call my families back to see how they're doing. That's not the practice of a lot of my colleagues. But again, I want to take those extra steps to see if there's something that they still need help with, or something that I can reiterate how important it is to follow up with their primary care physician. I will comment and say that COVID has really changed things dramatically. Primary care physicians aren't seeing pediatric patients in the office. If they have a fever, they tell them to come to the ER. So this whole piece about compliance and follow-up, it's just becoming more and more tangled and discombobulated and difficult for families to follow through.
I think you raised a good topic we should talk about a little bit too, Dr. Amy. What has COVID done and how has it impacted how each of you do what you do?
I think one of the things that we see most with COVID is just a highlight on healthcare disparities. I mean, it's one of the reasons we're having this conversation. So those of us, we've been in this career for a long time. You knew it was there. But I think what you see most profoundly when resources are limited and when the need is high is that some people can and some people simply cannot, right? And so I think it highlights the complexity of the situation, but it also makes it abundantly clear what organizations have to be responsible for, right? As mission-driven hospitals, so from the hospital perspective, as a mission-driven organization, I cannot simply be responsible for the patient once they show up at my ED. On discharge, we have to actively work with patients around discharge planning and services post-discharge, right? So to your point earlier around medicinal compliance and other activities, PT, whatever is necessary for a patient, that kind of outreach that Dr. Amy spoke to is in fact atypical, but it has become a responsibility because we care for the patients that we're serving. And so creating infrastructure to ensure that we can care for the entirety of the patient has highlighted there is some urgency, if you will.
Mm-hmm. She always gets to this point when she's making this really profound statement, and then
there is no doubt we have
you froze.
There is no doubt. There's no doubt that we have a profound responsibility, right? As we approach the second wave, how do we do it different? How do we do it better? So I think it daylights the issue and creates a sense of urgency.
Got it. Mm-hmm. Other thoughts?
Well, I think, what Michelle's talking about follow-up and outreach and what Dr. Amy was talking about in terms of calling and educating patients about, what services are there and to make sure that they know that there's resources, because I see that a lot with the families I work with too. There's just a knowledge gap. And it sometimes is profound I've had many families I've worked with where the moms grew up in an environment where they weren't even taught to brush their teeth. And I think that I gave the example too. My fiance, he's the same way. His family did not know about like dental care. And I think it was because they came from a working class background where they never had insurance for dental care. So they never went to the dentist. But once his dad, got employed at Detroit Diesel, was a union worker, then they had great dental care. And that was when they became educated because they finally were informed they had the resource to go do it. So there's definitely profound, not only racial, but socioeconomic gaps, I think, in access. Just knowing that you have these resources and there's things you can be doing to improve your overall health. And going back to the access thing, just to touch on it before I punt again, I really think that socioeconomic background and perhaps not knowing what options are there for you because you've never seen them. Those are the kinds of things that when the medical providers and the community is reaching out and educating and showing people you have these options, even if you are uninsured, even if you have Medicaid, it's really valuable, especially to the families that I work with.
Mm-hmm, mm-hmm. So Dr. Amy, Mary, what about COVID? How's it impacted what you do?
Go ahead, Mary.
Okay, so I think the saddest part is the lack of family members in the ICU, the visiting restrictions and not having the families present and having to do all of these difficult conversations over the phone and update many family members over the phone takes a good portion of my day, talking to let everybody know how so-and-so is doing because, you know, they need to know that kind of stuff. Also, it's difficult to get some consultants into the hospital because they're busy managing practices virtually and stuff. So we're even doing like virtual calls with like an ENT visit, you know, or like all these different, so it's a lot different than the way before where we would have these consultants all the time. Families would be present for big decisions. It's different.
Sounds like it's challenging.
So in the pediatric world, COVID has had an interesting impact on our care. Our numbers in terms of pediatric patient admissions have gone down dramatically. And then other parts of the country, pediatric emergency medicine physicians have been furloughed because there isn't enough work. So the fortunate piece of that is that kids aren't getting sick and they're not suffering the same kinds of consequences that adults are if they do get infected with COVID. The downside is that I think that the COVID pandemic is having a huge impact on the mental health of our pediatric patients, and that's getting ignored. It's impacting families. Kids are not being able to go to school and socialize with their friends. You have parents who are extremely stressed out trying to help their children with remote learning. There are so many components of this right now. And I don't want to leave you thinking like the kids aren't impacted by COVID. There are some children that are getting very sick. And so again, this is all a learning process though for us in the medical field because we've never dealt with this illness before. So I right this minute, I'm really concerned about the mental health of our pediatric patients and the adults in the community, because I don't think we're recognizing what kind of ramifications all of these things are going to have on the future.
Is there a racial disparity even on that end when you're saying like the mental health associated with COVID? Is there a racial disparity there?
I think absolutely. Again, I talked about pediatric services available in the community. Psychiatric services available in the Detroit community are almost non-existent. So if I have a psychiatric patient that needs care, it is extremely difficult to get them the services that they need. And then we're going to go back and talk about all of the access issues, right? Transportation. If you have an appointment an hour away at 10 o'clock in the morning and you have a parent that's working, is it going to be possible to get them to that appointment? So yes, there is absolutely a disparity.
Michelle, it looks like you were going to say something.
I was probably frozen. No, I'm kidding. No, so no question. Well, so I was going to make two comments. First, the mental health status of the country. I mean, we're a country in crisis in this moment. And so providing access to services, we've had to double down as an organization to ensure that our caregivers and employees have adequate mental health services. And what then must we think about those who don't have access to care, who are still grappling with coronavirus, with the racial tension, with this election? This has never been a more stressful year than in this very moment. It's just, we are in crisis. And so the lack of access results in a whole host of complicating factors, because of course there's a connection between your mental health and your physical health. And so you can't deny that. And so I think it adds to the complexity of the equation. The other thing I would say, I was just noticing in the chat, one of the things that we also saw during this time is people not coming in, or when they come in sicker, right? So when you don't have access to care, you put it off. I came and I tried to get a COVID test. Well, they just told me to go home and rest. Well, my chest was heavy and I just wasn't sure when to go back in. So I waited because I got turned away the first time. And so then I died. The other thing, or you come in and you're really, really sick, right? So you go right to a vent. The other thing that we saw is a significant decline in ED visits for like heart attacks. What happened to my stroke patients and my heart attack patients? It just makes you wonder, right? How many people were sort of left in the cold because they felt like, well, I don't want to go into a hospital because it's going to be dangerous. And or maybe this is something I should take care of myself at home. And then all of that's compounded by the fact that I don't really trust the healthcare system, because there's all of that whole history of trust with respect to women and communities of color in particular. And so a lot of people weren't accessing care. So I think the trauma of this is so incredibly profound. And as a society, it's like another thing that we need to continue to think about. What in the world are we going to, we've got a post-traumatic situation in 2021. What are we going to do to meet the needs of our children? What are we going to do to meet the needs of young people and adults who are dealing with, what probably, maybe not clinically, but probably comes close to a post-traumatic situation as we try to go back to life as we once knew it sometime late next year.
I can't agree with you more, Michelle. I mean, again, these are things we need to think about now. We're very reactive, right? We have to think about what's going to happen tomorrow and in the next couple of weeks. But I think the ramifications of this are greater than anyone has considered. One thing I recognize as a pediatrician, I'm smiling to kids and I'm playing with them and interacting with them, and that's part of my job. And I recognize how intimidating my presentation is now. To keep myself safe, I have to wear a gown. I have to wear 2 masks on my face. I have to wear a face shield. And so again, I can only imagine how distressful and that this is for the children and for the families. I mean, I come in and you can't even appreciate my facial expressions and interact with me. So again, every single component just to keep myself safe and to keep my patients safe, it is a challenge.
Dr. Amy, you mentioned something earlier about there's been more women present in the healthcare field. Has that shifted how healthcare is delivered? Or will that shift it?
I think it may, and it may not. I think that women have come a long way, and we're now welcome and we're at the table. But I'm not going to lie, there is still a lot of discussion out there in terms of how much I'm making as opposed to my male colleagues. There's a lot of literature on this. And so women are in the healthcare field, and it seems like we have more equal representation, but I don't necessarily know that we have equal compensation and an equal say at the table. I think that's something that we're still working towards.
Okay. So let's thinking about solutions and strategies. I know we said that that's not where most people are thinking. But if you were to think of solution strategies, and I'm thinking of like some of the demographics for the women lawyers, young moms, breastfeeding moms, some are older ladies who are going through menopause, perimenopause, all of that. How do we figure out how to make healthcare work for women, white, Black, various generations? How do we do that? What needs to happen?
Well, just from my observation, and again, I'm not a medical provider, but in the cases that I've handled, and I think there's some good statistical research too about just even the representation of women in the medical profession, and that they gravitate towards fields like pediatrics and OB-GYN, particularly for OB-GYN and childbirth work like what I do. I really think that historically women were not really represented in the ACOG, the American College of Obstetrics and Gynecology, who was writing papers and offering opinions and practice guidelines. And I always, when I look at the medical literature, because what I do is very much heavily based in understanding the medicine and why things are done the way they are supposed to be done, and when there's deviations from the standard of care in a certain situation. I just noticed there's not a lot of women, like even historically on OB-GYN, bodies that are doing research and conducting things. And so I just think, like, for example, in Europe, they have a tradition of, and in many other countries that have a better maternal mortality and morbidity rate than we have, they deliver babies standing up, right? Or they'll crouch or they'll do things. In America, we usually, we give medications to induce contractions. We deliver laying down, which it just seems like common sense to me. Why are we working with gravity more, right? We do let our moms get up and walk around and things, but childbirth in our country looks very, very different. And I always wonder, like, is it because there were not more women who've had this experience thinking about the process and thinking about what we're doing? So just as an outsider, I've always looked at medicine and I've looked at some of these studies where women are still not getting into, I think, the upper echelon of the people at these major research institutions that are making decisions about the healthcare we receive. So I always just, from an outsider, would love to see more representation across the spectrum, more equality. So, and I hope that we will achieve parity, just like we lawyers have, right? We're now in law school, we're getting more reflection of the population in terms of at least gender. We still have a long way to go in terms of race. And it sounds like from the other medical providers on this call, we still have a long way in the medical profession to go. You know, my clients, they very rarely get to see a doctor that looks like them. And I think that there is something about that, right? People in authority not looking like you or being like you, and how that affects, you know, the care you're being provided and the communication you're having.
Mhm.
So those are just my thoughts.
Thank you. Dr. Amy or Mary?
I can speak. I kind of along the lines of solutions. I was listening to NPR on the way to work the other day, and it was the first time I had heard a story about a mom who was having a hard time with the virtual schooling system and like the frustration about that. And I feel like nobody has really talked about how difficult that is. Like nobody's talking about how hard it is to do this. Like for myself and my husband with two little ones, a second grader and a kindergartner, you know what I mean? Like doing, you know, what's supposed to be the best young years of in school, and they're not liking school and all of that. But it was nice to be able to hear from on the radio a story about somebody who was also struggling with that, and like other options that they were thinking, like maybe we should just do our own homeschool program so that we could do something that's not so computer based and screen based, because we all worry about our kids having all this screen time. And then also, like for me as a parent, it would be very helpful if there was something from school saying, if this all doesn't work out and the kids don't do great with this, what are we going to do with it next year? Are the kids going to repeat school? Like, are they going to be okay? You know what I mean? Like, just because like you feel bad that you might not be doing the best that you can for your kids with this virtual schooling. So I think if we could move towards talking about, you know, in the future, what are we going to do for these guys to make it better for them would be helpful.
So I pick up that you're saying, let's acknowledge we got some stuff going on. Let's
Yeah.
have some conversation. Let's put it
Right.
in the mainstream,
Right.
and then have the collective conversation. Where do we go next?
Right.
Dr. Amy.
I think we've kind of lost sense of what's important. And I think we've lost our communities because we depend upon one another. And I think COVID has made that even more difficult, right? We have to social distance and we rely on one another. When you talk about a solution to getting access to healthcare, it's not just healthcare. We've got to come up with a solution for education and for employment and things like that. It's such an interdimensional problem, and we need all of the pieces to come together to fix it. But I feel like we've really gotten away from this whole idea of communities and things starting in the community and people taking care of one another. So I find that extremely frustrating because that's where a lot of these initiatives and solutions are starting. So that's hopeful, but not enough of it.
Got it. So if the panel's good right now, we're going to go